Hey team, welcome to the MMOA podcast. I'm Macy Bolt, outpatient PT and TA with the older adult division of ICE Physio. Today we are going to talk about the top 3 things to hone in on when it comes to osteoporosis management and how we can be better patient educators and teammates. We are going to dig into this with regards to someone who is newly diagnosed, feeling overwhelmed, and needing resources. A diagnosis of osteoporosis can be really, really scary for folks, especially when other providers sometimes frame it up as the brittle bone disease and people are told that their bones are paper thin. I have 2 patients who recently came to me having heard those words from other providers and feeling completely helpless with where to go next. One of them said to me, I don't even know if I'm in the right place, but I know I need help. And first off, I think this is a huge miss for my health system and for the health system in general. Um, and something that we're, really trying to actively change within my clinic, at least, because if people don't know that rehab providers can help with this, I think that that is something we need to be communicating with primary doctors, with rheumatology teams, with all of these specialists who treat these patients. Because if they don't know that we can help, then our services go so underutilized. So we've seen growth with this in many cases, but we still definitely have a long way to go. I don't know about you all, but when I see somebody who has osteoporosis on my caseload, I get super excited because I know that the interventions that I can provide can literally change the outcome of the rest of someone's life. And that's huge. It's motivating for us. It's so empowering for them. And I think that it's something that really is important. So one thing that we do need to realize with that is that we have a wealth of knowledge in these areas. And if we fire hose that information at people, we are going to watch their eyes glaze over and they're probably not going to hear a word of what we have to say. So when I see someone for the first time who has a diagnosis of osteoporosis and that's why they're there to see me, the first thing I always do is start by sitting down, introduce myself, and I give my background in treating osteoporosis. And then I open up the floor to them and I ask them, what questions do you have for me? And what do you already know about osteoporosis? Asking what questions they have at the beginning of the session might seem like flipping the script a little bit, as we usually ask this at the end of the session. But by asking those 2 questions, we can really dial in where the knowledge gaps are, what the patient is eager to learn more about, and how we can best serve that person. I also think it's really important to be taking notes as they're talking. Not only does it help my brain stay organized, but it also shows the patient we're taking what they're saying really seriously and making sure that we're not missing anything. Once we've established where the current knowledge base and gaps are, then we can create our education triage list just like we would for a patient coming in for balance concerns or back pain. So in my experience, there are 3 buckets that most of these concerns and gaps fall into. Number 1, lifestyle and nutrition. Number 2, exercise. And number 3, medical management. So we're going to start with lifestyle and nutrition. And it's really often thought that as rehab providers, we can't educate on nutrition, but we absolutely can, and we should be. If we're neglecting this part of our practice, we are doing our patients a huge disservice. And if you're thinking, I don't know if I have enough information to share with people, or I'm not confident in the information I do have, definitely check out the free resources section in the ICE Physio app. There is a free CEU course there called Nutrition Simplified, and it gives a really, really great foundational baseline of knowledge for you to kind of springboard off of and learn more from. So when it comes to nutrition with osteoporosis, I always want to know what my patient is currently eating, how much they're eating, and what supplements they're taking. I live in Wisconsin, where it's cold 50% of the year. And so nearly every patient that I see is prescribed vitamin D supplement. But in my experience, people don't always know why they are taking that and may not actually be taking it at all. So educating people that vitamin D is really crucial for calcium absorption is really can be eye-opening for a lot of people. And then another area I like to hone in on is how much calcium they are getting through their diet. Optimally, people are taking in calcium via diet and not only through supplementation. So, teaching that dairy products, leafy greens, seeds and nuts, and fish are good places of calcium is a really good place to start for a lot of people. Then, of course, we always talk about protein. Protein is the building block of muscle, and without good strength, our system is inherently less resilient. So, I always make sure that folks know how much protein they should be taking in, which is a minimum of 1 to 1.2 grams per kilogram of body weight for older adults. So, an easy way to do that math is to take their body weight in pounds, divide it by 2, and that's a pretty good starting point for protein intake for most people. Then, also educating on what good protein sources are is crucial because a lot of people feel like they can only get protein from meat, and that is not the case. Knowing that a lot of foods like Greek yogurt, nuts, and fish are high in protein and calcium, I like to think of this like a little bit of a cheat code for my folks with osteoporosis who may be new to looking at nutrition. Because if you can double dip and get both good protein and good calcium from the same food source, I feel like that's huge. So then the other half of the lifestyle piece of this, in addition to the nutrition, is talking to patients about alcohol use and smoking. I think most people inherently know that these things are not good for them, and they've heard that they shouldn't smoke and shouldn't drink from probably every provider they've seen since 1990. But if we can add a little more education as to why they should be avoiding these products, that may help kind of tip the scale into potentially some behavior change. So I often in my practice refer to alcohol and smoking as bone leeches because they literally leach the nutrition away from your body and your bones, which weakens your skeletal system. And I'm not kidding you, I really use those words with my patients. When it comes to patients who have osteoporosis, we cannot be using kid gloves with our education. We need to be giving people the cold hard facts so that they can take control of their condition. And I think conversations like this are incredibly important in order to create some meaningful change and some education points that are really going to stick with them. All right, so that is on lifestyle and nutrition. Now on to the second part of kind of the 3 buckets of education for osteoporosis, and that is exercise. So it is really well established in the literature that we need to have patients who have osteoporosis doing heavy strength training and impact exercise in order to see slowing and potential reversal of bony changes. So this means we cannot be doing seated TheraBand exercises and expect our patients to get better. We need to be teaching people how to bend, how to lift from the ground, how to rotate. We have to be getting people on and off the floor working on full body functional transfers. And we have to teach these people how to fall well. If we take a patient who has osteoporosis and all we do is tell them to be careful and give them underdosed exercises, that is negligence on our part because we know better. The research tells us better. And I personally have seen these improvements happen in my own practice. If what I said scares the crap out of you and you're like, no chance, Macy, I invite you to join us at a live course. We spend the whole weekend going over these principles of how to build strength, how to fall, how to get on and off the floor. And we do it in a way that is going to work for every patient on your caseload, regardless of their capacity. So that's just my little soapbox. Thanks for bearing with me. Now let's talk about what this looks like really on the first day of therapy. So step 1, just like with nutrition, is I want to find out what the patient is already doing. What does their current routine look like? Are they walking? Are they doing some kind of a strength training class already that we can just add to? Or are they completely sedentary and we're starting from square one? The last thing that I want to do is overwhelm my patient. So if I can take activities that are already a part of the patient's routine and just add different layers of strengthening and impact to those activities, that is a really, really great place to start for a lot of people. This is a process, and it is not a quick process. Bony changes take longer to show results than strengthening does, so I don't need to be giving them every intervention that I know at that first visit. We want to start somewhere and we want to build as we go. And we always want to respect the severity of the bony changes. So looking at a patient's T-score is really, really important. We want to respect their pain levels and we want to respect their fear and their kind of hesitation around some of these activities. If I send someone home with an exercise that terrifies them and they don't do it at all, that is worse than if I start small and intentionally underdose for a little while and then ramp up to an appropriate dosage as the patient's capacity and fear avoidance is improving. You also don't have to be doing things like box jumps in order to get people getting impact through their bones. Box jumps are great for some people. They do not work at all for others. And so if you have your patient already doing an exercise like a march, add a stomp to the march. If you have someone doing heel raises, have them, instead of a slow controlled lower, have them drop their heels down. Those are ways of adding impact to exercises that already feel very comfortable for a lot of people. And it's a great way to just get those bony changes moving in the right direction more quickly. It does not need to be complicated in order to be effective. And again, if you're feeling like you need more practice and ideas with this, please join us at a live course. So we have now talked about lifestyle and nutrition. We've talked about exercise. And the third big component is medical management. So we need to make sure that for these patients, there is someone on the healthcare team quarterbacking this. Because if that doesn't happen, things fall through the cracks. In a lot of cases, that is the primary care provider, but I've also seen this be a rheumatologist in some patient cases. And that person is really responsible for figuring out if medication management of their osteoporosis is appropriate. That can often help slow the bony changes, and they also are then responsible for making sure appropriate referrals are placed to a dietitian if needed. For future DEXA scans, we like to see those done incrementally. Usually they're done every year to see if things are progressing or staying stable. And then also to orthopedic, pain management, and rehab providers whenever appropriate. Our bias, of course, is that everyone should be referred to rehab for this. And as we know, like I talked about at the beginning, that's not always happening. So in my experience, we often have to be in really close communication with that person who is quarterbacking in order to make sure that lines of communication are open and that things aren't getting missed. You know, if the patient hasn't had a DEXA scan in 4 years, it might be time to get a repeat one. If, they're having more concerns about their nutrition or having GI issues, those referrals need to happen. And because we see the patients more often than a lot of people do, that sometimes falls to us to kind of triage that and figure out how to communicate with the quarterback in order to make sure that the appropriate referral gets placed. Research on osteoporosis supports the combination of medication management and exercise as the best solution for treating bony changes. And we should be helping to advocate for that whenever it's appropriate for our patients. The medications that are typically used are called biphosphonates, and they help by inhibiting osteoclast activity. So we're going to head back to biology class really quick. Osteoclasts are the bone breakers. They break down bone, and so by inhibiting their activity, we are slowing the breakdown of the bone. It really gives us a chance when those medications are on board to make some really positive bony changes by doing exercise and impact training. So those are the 3 buckets of education I focus on day 1 when a patient comes to see me with a new diagnosis of osteoporosis. So we have number 1, the lifestyle and nutrition education. Number 2, the exercise and impact training. And number 3, the medical management and making sure the team is in place. This is, of course, going to look different for every patient on your caseload. But if you can hit the main points clearly in that initial visit, give resources and materials for the patient to take home so they don't completely forget everything you said the second they walk out the door, and get them started on strengthening and impact activities, you absolutely will empower these folks who often feel very, very out of control with this diagnosis. I have had so many patients sit in my office and just cry at the end of these visits because they finally feel like they have a path forward. And we are the perfect providers to get them moving in the right direction. Thank you so much for listening. And if you're looking for more ideas on how you can best care for your older adult patients and learn some of the techniques I talked about today, please join us at an upcoming live or online course, which you can find at ptonice.com. Also, click the link below to receive our bi-weekly MMOA digest straight to your email with tons of great clinical tidbits. Can't wait to see you and connect soon.